I think that this is something that we as clinicians are trying to grapple. How do we do this? Because I think for years what we've been telling families and doctors is these patients have this food allergy, and the only option we had for them was A, avoidance, B, have epinephrine on hand in case a reaction occurs, and we're going to see you in 2 or 3 years to see if maybe you've outgrown it, maybe you haven't. And what you probably have grasped at this conference is that there's so much discussion about food immunotherapy. So how can we treat this potentially? So are there ways that we can integrate not avoidance, but giving very small amounts of this, whether it's something called EPIT on the skin, a patch on the skin, or orally by mouth. And I think that's something that we are all trying to figure out, how best can we integrate this. You know, there's an FDA approved product coming very, very soon. But despite that, we've been doing OIT now for over a decade. And I think that it suggests that the need for us to kind of integrate this is really very high. Patients want an option, and we as clinicians want to be able to offer an option. And I think that we're no longer in a state of equipoise where we don't which is better, which is worse. At this point, we now have options to offer our patients, and it's quite to me it's an exciting time. I mean, this is like it's going to be rewriting what we do, what the rest of my career is. So it's very exciting. You're right, and I think this is a really important point, because our diagnostic processes are going to change, because now we are faced with truly putting our money where our mouth is, right? Because in the past we may have had some uncertainty as to whether a patient was allergic or not. Our skin test may have supported that, but we may not have been 100% sure. But now, if we're looking at enrolling these families and these patients into these treatment procedures, these are long-term procedures, and they're labor-intensive. So you're right. Our testing, whether it's skin testing or blood testing, starts, but we are doing so many more what we call an oral food challenge, where you actually will give very, very small amounts of that in about a 2-hour period to see if that patient is allergic. It's what's called our gold standard, and unfortunately it hasn't been a major part of the allergy practice. A recent study from 2012 suggested that 70% of allergists in the United States only perform 1 to 5 oral food challenges a month. When you think about it, these patients are requiring multiple food challenges sometimes for the different types of foods that they're allergic to and are potentially allergic to before we enroll them into these therapies. And so to the point where, I know this is going to sound crazy, but we do about 12 oral food challenges every day now, to see if these patients are actually allergic, because the demand is so high. And our skin tests and our blood tests, they're good tests. It's not that they're not great tests, but they aren't perfect. And I think that the onus is on us now to make sure that if we are going to enroll these families, that we have the right diagnosis, and that's exactly what we see. We see that, fortunately or unfortunately, we're doing a ton more of these oral food challenges, and that has its own burden on our practices for sure. We need more space, we need more staffing, we have a risk of reaction.